Welcome to this explainer. Okay, today we are zeroing in on some seriously high-yield facts for your medical entrance exams. We're tackling leptospirosis and Weil's syndrome. Let's break this whole thing down together, kind of like a giant puzzle. So when you see these clinical vignettes on test day, you'll spot them from a mile away. We are going to build up your pattern recognition step by step, so the answers just become, well, second nature.
Right off the bat, let's test your gut reaction. What febrile illness gives you red eyes, severe calf pain, and hypokalemic renal failure? Just think about that for a second. Got a guess? Well, if you're picturing a specific hooked spirochete and thinking of Weil's disease, hit the nail on the head. You are absolutely on the right track. By the end of this, a clinical triad like that is going to be an instant reflex for you.
Okay, let's dive into this. Here's our quick roadmap. 1. Meet the pathogen. 2. Classic clinical clues. 3. Weil's syndrome triad. And 4. Diagnosis and treatment traps.
All right, Section 1. Meet the pathogen, Leptospira interrogans.
So Leptospira interrogans is a spirochete. If you look at it under dark field microscopy, you'll notice it has these really distinct hooked ends. But honestly, the absolute major takeaway for your exam vignettes is the zoonotic transmission. Rats. Rats are the most important reservoir you need to remember. The bacteria basically spread when infected animal urine contaminates water and soil. So what does that mean for your test? Look out for occupational risks. We're talking veterinarians, agricultural workers, maybe sewage or slaughterhouse workers, and you've got to be hypervigilant for recreational risks too. Like say a patient recently went swimming, canoeing, rafting, or, did a mud run in contaminated freshwater. The pathogen just sneaks right in through minor skin abrasions or mucous membranes.
So how does this actually build our clinical picture over time? Well, leptospirosis is a classic biphasic illness, and test makers absolutely love this. After a 1 to 2 week incubation period, we hit phase 1. That's the leptospiremic phase. It lasts about 3 to 10 days, and this is absolutely crucial. This is when the pathogen is actively multiplying in the blood. You can actually culture it right from the blood here. Then, usually in the second week, we hit phase 2, the immune phase. Now here's the key distinction. The leptospires disappear from the blood, and they set up shop in the urine, while the body starts pumping out antibodies. This immune phase is also when you might see complications pop up like aseptic meningitis. So remember, knowing exactly where the bug is, blood versus urine, during these two phases is a massive high-yield concept.
Let's move to Section 2, classic clinical clues and spotting those hallmarks. Okay, let's look at the absolute buzzwords you need to know. First up, conjunctival suffusion. And I really want to emphasize this. It is redness without exudate, okay? It's not a purulent pink eye, it's a capillary issue. That right there is an absolute giveaway. Second, severe muscle pain. We're talking intense calf or gastrocnemius tenderness, especially when you actually press on the muscle. And third, an intense frontal or retroorbital headache that honestly really mimics dengue. Look, if a question gives you a patient who, say, has a history of swimming in a lake, has red eyes with absolutely no pus, and severe calf pain, boom, you are diagnosing leptospirosis. No question.
All right, Section 3, Weil's syndrome triad, the severe beast. Now, Weil's syndrome is formally defined by a really severe triad: jaundice, acute kidney injury, and hemorrhagic diathesis. Let's anchor these 3 pillars in your memory right now. These are what transform a fairly straightforward febrile illness into a literal multi-system emergency. So let's break down exactly how each of these 3 presents, because believe me, they are completely full of exam traps.
And here is one of the biggest, the jaundice paradox. It's fascinating. In Weil's syndrome, patients develop this really prominent orange cast to their skin, and that's because their bilirubin is markedly elevated. But here's the trick. Their transaminases, the AST and ALT, are only mildly elevated. So what does that tell us? This jaundice is not due to fulminant hepatic necrosis. Test makers love to try and trick you into diagnosing massive liver failure here. But if those transaminases are only mildly bumped despite a massively high bilirubin, that's a huge flashing neon sign pointing away from standard hepatitis and straight toward Weil's.
Next up, let's look at the renal component. Acute kidney injury in Weil's is typically, initially at least, non-oliguric. But the absolute magic words for your exams: hypokalemia and urinary magnesium loss. This renal tubular wasting of potassium is incredibly characteristic of leptospiral nephropathy. I mean, think about it. Most other causes of severe AKI are going to make a patient retain potassium and become hyperkalemic, right? So seeing a patient with an AKI and surprisingly low potassium is incredibly unique and, you guessed it, heavily tested.
And here's exactly why identifying this stuff quickly matters so much.
The mortality rate for severe Weil syndrome can range anywhere from 1 to 50%. That is terrifyingly high. And that mortality is heavily driven by the third pillar, the hemorrhagic component, specifically pulmonary hemorrhage. Pulmonary hemorrhage is now recognized as a super common severe presentation and a major cause of death, sometimes even happening without the jaundice ever showing up.
So, think of these contrasting features like a mental set of flashcards. Mild disease, you've got little to no jaundice, maybe some mild proteinuria, and a mortality rate well under 1%. But cross over to Weil's, you've got that prominent orange jaundice, the hypokalemic AKI, severe hemorrhaging in the lungs or GI tract, and a mortality rate that can skyrocket up to 50%. The differences are literally night and day, and you've got to recognize the second a patient is crossing that line.
Okay, final part, Section 4, Diagnosis and Treatment Traps. Let's talk about diagnostic traps. The microscopic agglutination test, or MAT serology, is your gold standard. But pay close attention to the critical timing here. Antibodies only appear in the second week. That means your MAT is going to be completely negative in the first week of illness. So if you want to catch it early, PCR on blood is sensitive, but only in the first 5 days. So what's the clinical golden rule they want you to know here? Do not wait for serology before treating. Seriously, if the clinical picture fits, like you see that conjunctival suffusion and calf pain, you start those antibiotics immediately.
Let's just walk through those specific treatment algorithms step by step. Step 1. For mild disease, your absolute go-to is oral doxycycline, 100 milligrams twice a day for 7 days. Step 2. For severe disease, meaning Weil syndrome, you need to escalate rapidly to IV antibiotics. The drugs of choice here are IV penicillin G, ceftriaxone, or cefotaxime. And for exam purposes, these are all considered basically equivalent in clinical trials. And step 3, for prophylaxis in short-term high-risk exposures, remember that mud run we talked about earlier? You would use doxycycline 200 milligrams weekly. Take a second and let those drug names and dosages really stick.
Now there's a really cool, interesting detail here I like to call the doxycycline bonus. Why exactly is oral doxycycline the preferred drug for mild cases? Well, here is a super high-yield pearl. In a ton of geographic areas, rickettsial diseases, things like scrub typhus, are co-endemic with leptospirosis. And early on, they can present almost identically with fever and myalgia. Doxycycline is brilliant because it empirically covers both pathogens at the exact same time. But you've got to beware of the antimicrobial traps. Multiple choice questions absolutely love to throw in distractor drugs that sound strong but are completely useless for this. You need to know for sure that Leptospira is not susceptible to vancomycin, rifampin, metronidazole, or chloramphenicol. I'd highly recommend just committing this specific list to memory so you can rapidly, confidently eliminate them from your multiple choice options. Well, we have covered some fantastic high-yield ground today. You've mastered the classic clinical clues, that biphasic timeline, and the exact treatment algorithms. But I'm going to leave you with this final thought. Will you actually remember that the hypokalemia and intense jaundice in Weil syndrome do not equal liver failure when you're sweating under the pressure of a timed exam? Keep that paradox front and center in your mind. Review these concepts, visualize the patient, and you are going to completely nail those rapid review questions. Best of luck with your studies, and keep that focus sharp.